Hello, and thank you so much for joining us today. As the co-chair for the Cholangiocarcinoma Foundation's annual conference, I am so delighted to be here today and to speak to you all and provide a global clinical update for cholangiocarcinoma. It has been an incredibly exciting year, and I am so excited for the future, as I'm sure you all are. And I will give a brief overview in the next 15 minutes of what we have seen and what is coming in just the last year, but with the caveat that the next few days are going to really fulfill a much larger purpose in terms of explaining some of the things that I touch on briefly in much greater detail, because immense progress is happening across the world. These are my disclosures. So let's be honest, we have been showing this slide for a very long time. This is where we have been since 2010. The ABC02 study has been the pivotal study in the world of advanced cholangiocarcinoma since 2010. So for over a decade, we have been using gemcitabine and cisplatin as our standard of care backbone for chemotherapy in patients who have unresectable or metastatic cholangiocarcinoma. And while the addition of cisplatin did improve median overall survival, it is clear to me, as I'm sure it is to you, that we have a lot of work to do. Well, then we had this. We had ABC06. So ABC02 was 2010, and in 2019, we had the ABC06 study presented at ASCO. This was our second line study that was done by the same group in the UK, looking at patients who had already received gemcitabine and cisplatin. And in the second line setting, we're randomized to FOLFOX, which is 5-FU and oxaliplatin in combination, versus what's called active symptom control. Again, this was a positive study, so progress was made. That being said, while the hazard ratio was statistically significant, I have a hard time getting that excited about an improvement in median overall survival from 5.3 to 6.2 months. But regardless, it absolutely set a new gold standard and a bar for patients who had progressed on gemcitabine and cisplatin, and it verified what a lot of us clinicians already knew, that 5-FU and oxaliplatin is absolutely a potential chemotherapy regimen to use for our patients. Well, of course, we're always looking for hope, and I think there is so much hope out there. This is just one study that was done actually at MD Anderson Cancer Center that I think has given the community, the researchers as well as the patients and caregivers, hope. This is the GemCis nab-paclitaxel study that was initially done. It was a single-arm phase 2 study that we did at MD Anderson Cancer Center in conjunction with Mayo, Arizona. And this looked at a 3-drug chemotherapy combination in newly diagnosed patients with biliary cancers, which of course included cholangiocarcinoma. And as some of you probably know, this data was published last year in 2019. And again, a 3-drug regimen looked promising. There was an improvement in median progression-free survival and a stark improvement in median overall survival when you compare it to the historical data that we have from ABC02. Impressively, 20% of patients on this study who were told that they did not have an operation, did not have a hope for a cure, that they could potentially have received this chemotherapy and then been taken to the operating room for a curative surgery. So that was also quite exciting. And out of 12 patients, 2 of these patients had a complete pathologic response. There was no active tumor left in this specimen after receiving GemCis nab-paclitaxel. And as you can see, most of our patients actually derived benefit. Maybe not full partial responses, but most of our patients had some sort of tumor shrinkage. Well, that has led to the pivotal SWOG 1815 study. Now, this is a study that is ongoing across the country. It is through the NCI, and it is a randomized phase 3 study. Because, of course, the question is, gemcitabine, cisplatin, and nab-paclitaxel looks promising, but when randomized, is it better than gemcitabine and cisplatin? And that's what this study is asking. This study is asking the simple question of, can we do better than GemCis? The primary endpoint here is overall survival, and patients are being randomized 2 to 1. So 2 patients get the triplet, for every one patient who goes on the standard of care arm. And what I think is really exciting for this study, we don't know any data yet, but what is exciting is that in less than a year, this study accrued 268 patients. And it has now been expanded to 441 because we, as a community, all of you and the researchers, proved to the NCI that we can accrue a study like wildfire in this disease because of the commitment of the patients, caregivers, and researchers. Well, I think what's exciting is even already, based on the phase 2 data, the NCCN guidelines, when you look at the newest version that was updated in April of this year, we have GemCis, as you can see, listed on the left, but there's actually a fair number of other regimens recommended based on either single-arm phase 2 data or just other anecdotal data, in addition to the MSI high and some sort of what we call tumor-agnostic indications. And GemCis nab-paclitaxel is now also in the guidelines, which has made it easier for us as clinicians to get insurance to cover the 3-drug regimen. So what else is going on? Well, in Europe, they were looking at a 3-drug regimen as well. This is the 3-drug regimen we use in pancreas cancer of FOLFIRINOX, 5-FU, irinotecan, and oxaliplatin, and comparing it to gemcitabine and cisplatin. This was a phase 2 rolling into a phase 3 study, and all we know is that the study is not proceeding to the phase 3. So the 6-month PFS, which was the primary endpoint, progression-free survival at 6 months, that probably was not met for the phase 2, and that is why they're not moving forward to phase 3. But we're not giving up hope. We have other phase 3 studies ongoing looking at chemotherapy backbones. In addition to SWOG 1815, we have NuTide 21, which is a randomized phase 3 study looking at Nuke 1031, which is a nucleoside analog. So it's a drug very similar to gemcitabine, perhaps a little less toxic is our hope, in combination with cisplatin and comparing it to the standard of care gemcitabine and cisplatin. So there's a lot going on in the chemotherapy-based space where we can hopefully say we have more than GemCis. But let's be honest, I think the real excitement is in the molecular profiling and the genomic landscape that we know that comes from intrahepatic and extrahepatic cholangiocarcinoma. And you all, I'm sure, are very aware of some of the common mutations that we see, such as the FGFR2 fusions, the IDH1 and 2 mutations, and then rarer but still relevant mutations like BRAF and HER2 amplification or mutation. So the IDH1 mutation is really important because we have a drug, we have ivosidenib. This was looked at in a phase 1 study and published a few years ago and demonstrated that in cholangiocarcinoma patients with IDH1 mutations, this was a really well-tolerated drug and there may be some activity. So that led to the phase 3 Clarity study that you all probably are fully aware of. This was a randomized study 2-to-1 from receiving AG120 and placebo. The primary endpoint was progression-free survival, and crossover was allowed if patients had received the placebo and still met eligibility criteria. Well, this data was presented at the ESMO Congress in 2019, in the fall of 2019, by Dr. Abu Alfa and colleagues, and it did meet its primary endpoint. The hazard ratio was 0.37 with a statistically significant improvement in progression-free survival from 1.4 to 2.7 months. Again, not a dramatic number, but still a positive study and a drug that is really well tolerated in a subset of our patients who may be eligible. We all also are very familiar with the FGFR2 fusion story, which we see in about 10 to 15% of our patients. BGJ398, which is now known as infigratinib, was kind of the first one that we really tested with rigor. And again, in the last year, BridgeBio, which owns QED Therapeutics, received fast track designation for infigratinib. That is a huge deal. There's orphan drug designation as well. So the FDA took notice of this drug. Well, the nice thing about the FGFR2 fusion story is there's a lot of drugs in this space. There are drugs such as futibatinib, and this is the updated data that was presented just a few weeks ago at ASCO, that basically, just like infigratinib, included patients with FGFR2 fusions with cholangiocarcinoma. And as you can see, the objective response rate was 37.3% with one complete response. And look at that waterfall plot. This drug works in this subset of patients. Progression-free survival is listed here, 7.2 months, again, in a refractory patient population. This is a noticeable PFS. This is relevant and clinically important. So we started with BGJ398, then we had futibatinib. Well, we also had pemigatinib, and that data was presented at ESMO 2019. We have the Arcule compound and the Debio compound. But I think most exciting is that in the last few months, we have our first FDA-approved drug for cholangiocarcinoma. The FDA approved pemigatinib as the first targeted treatment for adults with previously treated unresectable locally advanced or metastatic cholangiocarcinoma. This was a huge win for our community. We have never had an FDA drug approved, and this is such a huge step forward for us. So what about other targets? Well, we also had studies that were looking at targeted therapies in unselected patient populations, like the Treetop study, which looked at a small molecule HER1, 2, and 4 inhibitor in an unselected patient population after gemcitabine and cisplatin. Well, Dr. Javle and colleagues presented this data at ASCO. Unfortunately, this was a negative study. So giving a targeted therapy in an unselected patient population, at least this targeted therapy, does not seem to work better than just giving oral chemotherapy, capecitabine alone. I think the other really exciting space is what we call circulating tumor DNA. So these are the liquid biopsies as we talk about them, as opposed to tumor-based next-generation sequencing. And I think what we're learning is that there's a lot of different ways that we can use ctDNA. And in the last year, a lot of data has come out that has kind of supported that. Well, first, we had a paper that had been published a little while ago out of the Memorial Sloan Kettering group that suggested that you can use ctDNA to understand IDH1 resistance. And this was just one patient that they reported on that demonstrated a response to ivosidenib. And as they responded, the IDH1 mutation kind of disappeared in the blood, the levels. And interestingly, as the patient became resistant to ivosidenib, an IDH2 mutation was noted, a clone was noted in the ctDNA. But this was an N of 1. Interestingly, at ASCO this year, with the help of Agios, which is the company that has ivosidenib, they also demonstrated that clearance of the mutant IDH1 in ctDNA demonstrated or correlated with progression-free survival. So you can see in this graph that those who cleared it had a better PFS than those who did not. So perhaps this can be used as a way of tracking response and progression-free survival data. And we, I think, have made a lot more strides in the FGFR2 resistance story. This is a very elegant work that was done for Mass General with Dr. Goyle and colleagues. And again, I'm not going to go into the details here, but the important point is that we can follow patients' response to oral FGFR inhibitors. We can see the emergence of clones, resistant clones in ctDNA. And as we learn what those mutations are doing to the structure of the FGFR2 binding pocket where some of these drugs bind, for instance, we may have some clues about other FGFR inhibitors that could have utility after progression on one. So it helps us, as we have multiple drugs in this space, think through how we can sequence patients with FGFR inhibitors. And then, of course, immunotherapy. Well, immunotherapy, we've had a number of studies in the microsatellite instability high space that we know pembrolizumab is approved in and it can work in. But the initial data, I have to be honest, I was underwhelmed. In Keynote 158, there was 104 patients with biliary tract cancers, and the overall response rate was 5.8%. It's a little leaves a lot to be desired. But then we also had Dr. Kim's data published this year. Now, this was a multi-center study looking at nivolumab, again, a checkpoint inhibitor. And in this study, there was a response rate of investigator review of 22%. Admittedly, on central review, that response was 11%. But again, intriguing and makes us get a little bit excited that perhaps immunotherapy can play a role here. Then we had the data presented at AACR this year by the Johns Hopkins group looking at a combination of checkpoint inhibitor and atezolizumab and cobimetinib, which targets the MEK pathway. Now, a lot of these are This was a multi-center study, and a lot of these patients were accrued rapidly, again, proving to the NCI that we can do this quickly. And the patients were randomized to receiving the checkpoint inhibitor alone versus the combination. And the progression-free survival, median PFS for the single agent of the checkpoint was only 57 days, but the combination was 111 days. And importantly, it seemed that a lot of that benefit was driven by the intrahepatic cholangiocarcinoma patients. So perhaps this may be something to think about in that patient population, unless it's just related to the biology of those patients compared to the others. But the disease control rate was 45.2% in the combination arm and 32.4% in the single arm of atezolizumab by itself. Again, raising our eyebrows, making us excited. And then just last but not least was the study provided by Dr. O at ASCO this year, which this is a very complicated slide, but the important parts here are is this was looking at gemcitabine and cisplatin in combination with either durvalumab alone, which is another checkpoint inhibitor, or durvalumab plus tremelimumab, which is an anti-CTLA-4. And again, what you can see here is some impressive response rates. Now, what exactly that means, because this was a study done in Asia, and we know that the Asian population is a little bit different than the Western population, is hard to know, but there are ongoing studies that I think are going to help us better understand what a gem-cis plus immunotherapy combination can do when you accrue globally. So some of the complexities that remain, though, we still have the same issues. The availability of tissue and the importance of doing next-generation sequencing we know, but sometimes it's hard to do that. Well, in those cases, can we use blood-based assays like ctDNA? I think it's important that we acknowledge that ABC06 is out, and that is the new second-line standard of care, and we really have to use that as our new benchmark. And a lot of these studies have been single-arm studies. We really need randomized studies, so I applaud the ETCTN study with the cobimetinib and atezolizumab. But we also know that all cholangiocarcinomas are not created equal, and we're still learning how to stratify them and how to do basket trials to allow for a nimble evaluation of some of these rare subsets. And I still think we're still learning about the role of resistance and how and when to repeat biopsies and how to use ctDNA. But in conclusion, I think it is absolutely an era of new hope with a bright future ahead. Even in chemotherapy, we are making progress. Sequencing can and should be done on all patients. I think we all know that. We importantly have a drug FDA approved. Actionable targets exist, and we want to go after them with smart clinical trials. And I absolutely remain hopeful for immunotherapy. I think these last few studies raise the bar a little bit and make us excited that we are going to be able to find how and when to utilize immunotherapy. And with that, I thank you. Please feel free to reach out with any questions.